Thank you, Donna, and good evening, everyone. I'm Robin Toohey, Vice President Support Groups, and along with Susie Durie, President and co-founder of the International Myeloma Foundation, it's our pleasure to welcome you to tonight's teleconference on the Best of ASH 2019, What Patients and Caregivers Need to Know. ASH is the annual meeting of the American Society of Hematology. It's the world's premier event in hematology where a global community of more than 20,000 hematology professionals from every subspecialty gather to hear highlights of the hottest topics in hematology. And this evening, Dr. Brian Durie will discuss key takeaways from the annual conference specific to multiple myeloma and explain how this new and important information relates to patients and caregivers. If you have not yet accessed tonight's slides, you may do so at www.myeloma.org. Additionally, to help you better understand some of tonight's slides, we have included links to myeloma terms and definitions and also myeloma acronyms that are commonly used. And you can find these links right below the green button where you downloaded tonight's slides. And you might even want to print these out for future reference. I know it really helps me to keep all of these acronyms straight. And I know that Dr. Durie is going to do his best to make sure that you understand what this all means. And at the end of tonight's discussion, Dr. Durie will take questions, so be prepared with your questions for after his presentation. I'd like to take a moment to thank our sponsors for their support of tonight's call. And though they are Bristol Myers Squibb, Janssen Oncology, Sanofi Genzyme, and Takeda Oncology. And it's now my pleasure to turn this call over to Dr. Brian Durie.
Well, thank you so much, Robin, for that very kind introduction. I'm very pleased to be able to make this presentation tonight about the Best of ASH 2019. If we go to slide number 1, just as an introduction, I would like to draw attention to the fact that 2020 is a very special year for the International Myeloma Foundation. It is our 30-year anniversary, and so you're going to hear a lot of follow-up details and celebrations of that 30-year anniversary. We are particularly pleased that this 2020 year will be pivotal for a number of our key projects, in particular the CURE trials, part of our Black Swan research initiative, and then also prevention strategies related to our activities in Iceland, the iStop-MM project. But going to slide number 2, I want to draw attention to the fact that, in fact, we have a very large number of resources available related to ASH 2019, as you heard, is a very major meeting for the myeloma community. And so these items listed on slide number 2 are clickable, and so those are resources that will be available to you to follow up on what I will provide tonight, which are basically the high-level takeaways from the ASH 2019 meeting. And so if we go to slide number 3, the key takeaways, I will focus on 5 different areas. The first one is smoldering myeloma. The second is frontline therapy. The third one is potential approaches using precision medicine. The fourth one, the very active area of immune therapies, CAR T cells, bispecifics, and monoclonal antibodies, and then novel combinations. So going to slide number 4, smoldering myeloma, the main aspect that I want to discuss is what is high-risk smoldering myeloma. HR in this case means high risk. Let me just say, first of all, that the risk relates to the risk that the disease will move from an early smoldering state into myeloma it does not relate to the risk of the disease itself. It's related to the risk of this likelihood of moving forward into an active form of the disease. And it's key to understand how to determine if a patient has high-risk smoldering, but also at this juncture in 2020, how should this be managed? If you go to slide number 5, there is summarized there an IMWG classification for high-risk smoldering myeloma. For those of you who may be looking at this slide on the computer, you will discover that it is clickable. If you click forward, you will activate the different steps on this particular slide. The first step to activate is on the left to 2020, which is the model for the classification of high-risk smoldering myeloma. And so what does this mean? This means that if the level of the monoclonal protein is greater than 2 grams, that would be the 2. If the free light ratio, or the FLC ratio, is greater than 20, then that would be one of the factors. And then if the percentage of plasma cells in the bone marrow is greater than 20%, this would be another factor. And so if the numbers reach these breakpoint levels of 2, 20, and 20, this indicates a likelihood greater than 50% that the disease will progress to active myeloma within 18 months to 2 years. Now, if you click forward on this slide, we have refined this model so that individual numbers from individual patients can be used, so that if one of the numbers is a little bit below 20% or below 2, then actual numbers can be loaded in and a risk score can be calculated, and it allows patients to be classified into high risk where there is a high likelihood of movement towards active myeloma within 2 years or not. And so this new tool using individual numbers is being developed in the form of an app which will be released within this first quarter of 2020. So you can be looking out for that. This app can allow one to assess if a patient is low risk, which is perhaps equally important. If you are in this low risk category, there is, for example, maybe a 5% chance or less that the disease will move forward within 2, 3, 4, 5 years. And so this knowledge is possibly just as important as the opposite, where we might want to be alert about a likelihood of active disease coming soon within 18 months to 2 years. And so if we go to slide number 6, the next slide, why is it that we are so focused on this high-risk smoldering myeloma? Well, the rationale is that it can allow us to intervene early in a secure way. If we know that a patient has a very high likelihood of developing active myeloma soon, then it means that if we intervene early with some type of therapy, then we can have the best chance to do the most excellent job possible with currently available therapies. And so, as part of the Black Swan Research Initiative, for example, this opportunity can allow us to have protocols where we are targeted on attempting to try to even eradicate all the disease and to achieve cure for myeloma. And I'm going to go into that in more detail in the coming slides. If you look online, you will discover that right now there are, in fact, 51 clinical trials listed on clinicaltrials.gov looking at various protocols for the treatment of smoldering myeloma, particularly high-risk smoldering myeloma. This is really pretty amazing. However, most of these treatments are focused on delaying the progression. They're giving milder, gentler treatment, something like Len and Dex or some other simpler combination versus a more aggressive approach. And there is a question about what is the value of that. Always there can be a delay of progression if you give some kind of treatment, but what is the value of that delay in the big picture in the long term, and how will it ultimately impact the overall survival? And these are key questions that we don't know the answer to just yet. And so through the Black Swan Research Initiative, we are actually much more interested in if we can be moving towards achieving a cure using a more decisive approach, either the Caesar trial, which is KRD plus autologous stem cell transplant consolidation and maintenance, or the new ongoing trial in the U.S., the ASCENT trial, which is KRD plus daratumumab with or without transplant. And this is a protocol of particular interest to patients here in the U.S. If we go to slide number 7, we can see that the results have been really extremely good using the Caesar trial. And so in this trial, patients with high-risk smoldering myeloma, they receive 6 cycles of Kyprolis, which is carfilzomib, Revlimid, and Dex for 6 months. Then they will receive autologous stem cell transplant, and then consolidation and maintenance, as you can see listed on this slide, on slide number 7. And you can see of the 90 patients in this trial, 77 of those patients have moved all the way through into that maintenance period already. And the really great results are that 81% of the patients have had a complete remission or a stringent complete remission, and 62% have achieved an MRD negative status at the 10 to the minus 6th level. And that means that checking 1 million cells in the bone marrow, no myeloma cells have been found. And so this is called MRD negative at 10 to the minus 6. And so this is obviously very good. And if you go to slide number 8, you can see that we list the PFS and the overall survival. And so PFS is basically the length of the remission. And you can see that 92% of the patients are still in remission at close to 3 years. And the overall survival is 96% at 3 years as well. So really spectacularly good results with this. And so the $64,000 question is, how many of those patients are going to remain MRD negative and in remission, and for how many years? And we're really quite optimistic about that. And so what we decided to do recently was to evaluate all of these patients using a very, very sensitive technique to measure the amount of myeloma protein in the blood. And this technique is called mass spectrometry. And if you go to slide number 9, you can see a discussion about what is the role of quantitative immunoprecipitation, QIP mass spectrometry. And basically, the myeloma protein is detected based upon its mass or its weight, and that tells you specifically that it's a monoclonal protein, and the amount is determined by the height of the spike, the red spike, which is shown in the middle of this slide. And so it's very, very similar to a serum protein electrophoresis, but its weight is based upon the very specific mass or weight of the protein. And so this is a very, very sensitive way to measure the amount of myeloma protein in the blood or in the urine, for that matter. I'm going to show you data for the blood. And so if we go to slide number 10, monitoring within the Caesar trial, and this was done by Mary V. Mateos in collaboration with Stephen Harding at the binding site in Birmingham in the United Kingdom. It was clear that the mass spectrometry was much more sensitive than using traditional SPEP, which is serum protein electrophoresis and immunofixation, to pick up the myeloma protein, much more sensitive. But what was really surprising and is incredibly important, if you go to slide number 11, it became clear that patients who were MRD negative in the bone marrow at this 10 to the minus 6, some of those patients were having positive results with mass spec. We were picking up myeloma protein in the blood of patients who we otherwise thought were in remission, a full remission in the bone marrow. And so if you go to slide number 12, you can see, well, what are explanations for that? Why would a patient be negative in the bone marrow at 0 out of 1 million, but still have some protein present in the blood? And so one idea is that for those patients, there could be patchy disease in the bone marrow. Another possibility is that there could be lesions outside of the bone marrow, maybe in the soft tissue or elsewhere, that are not being picked up. But the key thing from a monitoring standpoint is that the mass spectrometry is going to be incredibly important, because if we're having a positive result, it tells us that there must be some residual disease somewhere. And so our goal now is to achieve both MRD negative and also mass spec negative to be sure that there's not disease hiding anywhere. And so if you go to slide number 13, this kind of summarizes where are you in the terms of an algorithm for managing patients who have potential new myeloma or smoldering myeloma. And the algorithm is relatively clear-cut. If you do have myeloma-defining events, CRAB features, or the other defining events, then you should be treated as if you have myeloma. If you have the smoldering myeloma, or including the high-risk smoldering, there are options listed there. The main one that I would emphasize is that the standard of care does remain observation, careful care for observation, while we're waiting the results of the clinical trials. There has been recent discussion based upon an ECOG study, Eastern Cooperative Oncology Group study, that maybe taking just lenalidomide, Revlimid alone, could be offered to such patients, and some people do consider that. However, this is really not a decisive treatment, but is delaying progression. And I think that most people are still comfortable to either observe or enter a patient into a more decisive clinical trial. So if we move forward, then the next step is a frontline therapy for patients who definitely do have active myeloma. And on slide number 14, the $64,000 question in this category is, should we now be switching to be using a 4-drug regimen? So that right now the standard of care is a triplet, three medicines, 3 drugs used together. The standard of care is currently Velcade, Revlimid, and Dex as that triplet. And the question is, should we be giving it along with daratumumab, the monoclonal antibody against CD38, to give a 4-drug regimen? Obviously, there's also another monoclonal antibody like that called isatuximab, but it has been not really tested that much so far in the frontline setting. And so if we go to slide number 15, what we see is that the results with triplet therapy with VRD plus stem cell transplant, with, for example, the IFM 2009 study, the PFS and the overall survival, so the length of the remission is around 4 years, and the overall survival is really excellent out to 4, 5, 6 years. And so the triplet therapy is really producing excellent results. And in the IFM study, the outcome was largely dependent on whether or not patients achieved an MRD negative or not. And so if MRD negative was achieved, then the blue line on the overall survival curve indicates that those are the patients who were doing well longer term, but really a vast majority doing very well with the triplet therapy. And so if you go to slide number 16, there has been an effort to improve the triplet therapy, and that is by switching from 4 cycles of Velcade, Revlimid, and Dex, and using 6 cycles. And so the Spanish team in the GEM 2019 trial, they created a very clever regimen where, in giving the VRD, they gave the Velcade twice a week subcutaneously for 2 weeks on a 4-week cycle. And this meant that it was broadly well tolerated, and it was possible for all the patients to actually receive the full 6 cycles of the induction. And this has produced really the best results that we've seen so far with a triplet therapy. And so clearly, using this kind of a regimen, a triplet can give you quite excellent results. And so if we go to slide number 17, the question is, how much better can you do by adding in the daratumumab? In this case, a European trial where they use thalidomide instead of Revlimid. So this is VTD, and combining it with Dara. And the violet curve here shows you to get patients who are negative with this MRD testing and also have a negative PET-CT scan. These patients are doing very well out to 2 and 3 years with the 4-drug combination. But these are early days because you can have results, as I just showed you, very similar to that with the triplet. So it's going to take some time to see how much added benefit there is with the 4-drug versus the 3-drug. And so if we go to slide number 18, another study was presented at ASH, abstract number 691, where they did give the Dara along with the VRD, and this is called the Griffin study. And again, you can see spectacular results, 95.8% remissions out to 2 and 3 years, and overall survival really, really excellent with MRD negativity out in that 2, 3, 4 year range. And so excellent results. It's just going to take time to see what is the added benefit versus a triplet. And then finally here on slide number 19, Dara is given along with, instead of Velcade, Kyprolis, which is carfilzomib, so Dara KRD plus an autologous stem cell transplant. So 4 drugs plus a stem cell transplant. And you can see here as you go from left to right, looking at traditional response, 91% of the patients as their best response had a complete remission or a stringent complete remission. And the patients on the right assessed by MRD testing, 80% of them were MRD negative at the 10 to the minus 5 level. 65% of the patients had MRD negative at 10 to the minus 6 level. So really spectacular results. And you can see that these numbers are quite similar actually to what I was mentioning related to the treatment for high-risk smoldering myeloma. And it does seem that with our currently available therapies, we can achieve an MRD negative in the 60 to maybe 70% range. Really, really excellent. But there is less added benefit the more drugs that you add in. And so if we go to slide number 20, will Dara plus a triplet become the new standard of care? And we're really just not sure yet. The Griffin trial suggests that Dara VRD could become the new standard. Dara KRD, which is maybe more effective in patients with high-risk myeloma. And then other options for other categories. However, I think that there could be some tendency to stick with the simpler triplet therapy for the time being. If we go to slide number 21, this kind of gives you the summary algorithm that we're using to try to work through these options for now. For the transplant candidate, VRD, or think about Dara plus the VRD, for example, and then for a non-transplant candidate, something simpler. Again, thinking about whether we might add Dara in for a quadruplet or maybe a new quadruplet. I can draw attention to the fact that on slide number 21, that there is still a sense that transplant is an important part of the mix, and that outside of a clinical trial, we should still be strongly considering transplant for patients who are able to pursue that and are eligible and are interested to go that route. So moving forward to slide number 22, moving into a third area which was quite interesting at ASH, and that is, can we select treatment for individual patients based upon particular lab test results or the special options in therapy that are currently available. And so I'm going to show data related to the FISH testing results related to chromosome number 1q21, and then this translocation 1114 involving chromosomes number 11 and 14, and then some other details related to the treatment options. And so if we look first of all at a study that was presented at ASH in slide number 23, this is abstract number 4343. Patients who have this abnormal problem with chromosome number 1, where there's an extra piece on the bottom part of chromosome number 1, it's called 1q21. What these different charts show is that the patients who have this, and in addition have the translocation with the 414, this combination, those are the patients who are at the highest risk and where we need to be looking at better and newer approaches to treatment. And so we need to pay more attention to this problem with chromosome number 1 than we have been up to the present time. And so another interesting thing on slide number 24, the next slide presented at ASH, is that in abstract number 4580, it turned out that if you look at patients who have the 1114 chromosome abnormality, that these patients seem to do particularly well with autologous stem cell transplant. And so in trying to think about the pros and cons of transplant, it seems like for a patient with this 1114 chromosome abnormality, stem cell transplant should certainly be considered strongly because it does seem to have a more powerful beneficial impact. And then if we go to slide number 25, for this exact same type of patient, there is a drug called venetoclax, which works against BCL2, which is increased in patients who have this translocation 1114. And so in this situation here, where there is translocation 1114 or this high BCL2, which is a protein in the cell related to the way that the cell is growing, if you give venetoclax to patients who have this type of myeloma cell in the bone marrow, they seem to respond extremely well versus giving treatment which does not include the venetoclax. So bortezomib and dex with venetoclax is very, very good for those patients. However, if you look to the right on this slide number 25, you'll see that if patients do not have this 1114 or they have low BCL2, there's no added benefit with the venetoclax. So it seems that the venetoclax should really be reserved for patients with the 1114. If we go to the next slide, just an interesting small point here, abstract number 139, in patients who have amyloidosis, a cousin to myeloma, a very interesting paper showing that ixazomib, which is a proteasome inhibitor similar to Velcade and Kyprolis, given by mouth, patients with amyloid here were benefiting with ixazomib plus dexamethasone versus what had been the physician's choice up to now. So very interesting point related to amyloidosis. And so in summary here in slide number 27, what are some newer things to be thinking about related to precision medicine? Well, for sure, we need to pay better attention to the 1q plus abnormality, which shows up on the FISH testing, the chromosome testing of the bone marrow, and that we should be considering for patients with the 1114 that autologous stem cell transplant, ASCT, is particularly beneficial, and the study is suggesting that venetoclax, this new medicine against BCL2, should be strongly considered as the trials are moving forward with that. And then, interestingly, that ixazomib, the oral proteasome inhibitor, seems to be helpful and useful for patients with amyloid and also other patients who have a lot of other issues of patients who might be unfit or frail, this oral proteasome inhibitor can be an attractive option. And so let me move forward into what was possibly the major area of new data at ASH this year, which is the immune therapy results. And so I think everyone was so keen to hear what were the results with CAR T therapy, with bispecific T-cell therapies, and also monoclonal antibody drug conjugates. And so if we go right into that, first of all, with the CAR T-cells, this is a technique where with engineering the sequence for what we're interested in, and in this case, for now at least, we're interested in BCMA, B-cell maturation antigen, that can be inserted into the T-cell. So using a viral vector, you can put that into the DNA of the T-cell so that then the T-cells pick up that sequence and then can tag in with the myeloma, which has a lot of this BCMA on the surface. And so you can take the T-cells out of a patient with myeloma, you can put this sequence into the T-cells, and so then the T-cells are armed and ready to attack the BCMA on the surface of the myeloma, and this has turned out to be an amazing treatment approach. And many people have said, okay, is this CAR T therapy a game changer for myeloma? And it seems that it may well be. And so the reasons that we say that include, if we go to the next slide, slide number 30, the CARTITUDE study, which was presented at ASH, abstract number 577 on slide number 30. The first thing is to say that in this case, the CAR T therapy is safe. It's a very dramatic therapy, and there have been concerns about something called CRS, the cytokine release syndrome, such that if the treatment is working really dramatically, you can get side effects, including neurologic, neurotoxicity side effects. However, on the chart here, the colored chart on slide number 30, you'll see that the high-level toxicities were very, very few in this case. And so that was extremely good news that this was well tolerated. And then people ask, if you go to slide number 30, what did you learn when you went to ASH that you did not know from reading the abstracts? Well, in this particular case, it was interesting. Dr. Deepu Maduri, in slide number 31, she really did an excellent job in presenting the results of this CAR T therapy. She showed that the efficacy the safety was good, and then went through to show on the next slide, slide number 32, that the responses were really amazing, and she made the effort to say, well, let's take a moment to pause and take a look at this particular graph on slide number 32, which is called a waterfall plot. And so what it shows, all the blue bars show the amount of the reduction of the myeloma. And you can see that most of the patients have got complete blue bars, which means that they've had dramatic response to the myeloma from the CAR T therapy. Actually, 100%, all the patients have some reduction in the blue bars, and most of them have a dramatic reduction in the blue bars. And so I think it was very appropriate that she said, let's just stop and think about this for a minute. Here we have a treatment that is producing this level of very, very deep responses in what seems to be rather a safe way. So I think that people did pay attention to that at the time of the meeting. And so if we go to slide number 33, I want to draw attention to the fact that these CAR T therapies are actually coming out of China in an important way. That particular trial that I showed you is a Janssen trial conducted in the U.S., but it was using a methodology that was developed back in 2018 by the Nanjing Legend Biotech Company in China. And then what I'm going to show you in a second is that a second method was developed and is now a method that was presented at ASH this year. And the number 4 is a newer method which had preliminary results at ASH as well. And so this trend of therapies like this coming out of China has been a dramatic switch in the way that we look at treatment development. If we go to slide number 34, this just shows you the second product coming out of China, which is called an HRAIN product. And the main point here is to show that, again, we're seeing very, very dramatic benefit with this. It has a safety switch in it, which means that you can shut off the activity of the lymphocytes if you're getting too much toxicity. Very, very helpful. If we go to slide number 35, this shows you the results with another immune therapy, which is called a T-cell engager. And what this means is that it pulls the myeloma cells close to the T cells, so that you don't do anything with the T cells. You just give this monoclonal antibody, and it brings the T cells close to the myeloma, and then that can lead to the destruction of the myeloma. And this was an early phase 1 trial shown in slide number 35. As you go from the bottom up to the top, you'll see there are a lot more blue bars at the top, and that means that as they increased the dose in this phase 1 trial, they started to see better and better responses with sustained benefit. And I think the people were quite impressed that at the optimal dose level, some very, very dramatic responses were seen with this particular type of monoclonal antibody, a T-cell engager. And it has 2 heads, anti-BCMA2, so it has 2 heads that attach to the myeloma. So it strongly pulls the myeloma and the T cells together. And so if we move to slide 36, a final type of immune therapy that was a hot topic at ASH was using a monoclonal antibody linked to a drug. And so if you look at slide number 36, there are little yellow stars which are attached to the monoclonal antibody. And when the antibody attaches, those little stars, they move into the cell, and so the drug actually contributes to the destruction of the myeloma. And so there's a lot of interest in this type of a way of attacking the myeloma. And this particular drug, if you go to slide number 37, it has a long name. The acronym that we're using for this is BELA, so just the first 4 letters. This BELA monoclonal antibody drug conjugate, again, it has this waterfall plot showing that a majority of the patients, 60% of the patients, had very, very good results with this monoclonal antibody. And the advantage of that is that this is what we call off the shelf. With the CAR T cells, there's a manufacturing time where you have to harvest the T cells from the patients. They have to go off to the engineering factory, and then they come back 3 weeks later. With this, you can just come into the clinic and treatment can be given right away. And so there's a lot of interest in this more direct, off-the-shelf type of an immune therapy. So a very, very important option. And so slide number 38, these immune therapies clearly very, very active in relapse patients against this B-cell BCMA target. And there's a lot of interest in how we can best use these perhaps a little bit earlier in the disease for consolidation or a first relapse to get the most mileage out of these new therapies. And so finally, just briefly in closing, I want to mention some novel combinations. We have a lot of drugs that have been approved in recent years. And so on slide number 39, I summarize a number of those. And so it was encouraging to see good results with some of the newer combinations. If we go to slide number 40, for example, the combination of daratumumab with Kyprolis and Dex, DARA-KD. This particular study, the CANDOR study, showed that the 3-drug combination was better than the 2-drug combination. A number of advantages of that is that it does not have any IMiDs in it. It does not have any Revlimid or pomalidomide. So very important for patients who have either failed those or are no longer able to tolerate those well. So an IMiD-free combination, which also works well in patients who have high-risk cytogenetics. So there was a lot of interest in this CANDOR study, which was actually presented by Dr. Saad Usmani as a late-breaking abstract. So a lot of interest in that. Slide number 41, daratumumab plus pomalidomide and Dex. Also excellent PFS and overall survival with this in relapse refractory patients. And then slide number 42, another word for you just to be familiar with a little bit, iberdomide. This is an agent which is similar to an IMiD, so it's something which is similar to Revlimid or pomalidomide, CC220, and with responses a little bit better than 30% in patients with refractory disease. So a lot of interest in this as a simple new IMiD type of an approach. And so in summary, at the end here, I give you a couple of algorithms just so that you have them for reference. For relapse now, for patients who are not refractory to lenalidomide, so not refractory to Revlimid, slide number 43, you can see there's a number of options. Patients who are refractory to lenalidomide, again, options like an IMiD-free combo that I just mentioned. And then finally, for patients who've gone through a lot of different therapies, we have a lot of different variations of these combinations, and then a lot of additional options for later, including these immune therapies, but also some things that I haven't had a chance to talk about, like melflufen, and then also selinexor, which was recently approved. So really a lot of additional options. So very, very encouraging to hear all of this good news at this ASH meeting. So thank you for watching and listening, and I'm going to stop now with 10-15 minutes left for questions. So thank you for your attention.
Your first question comes from the line of Dana. Your line is now open.
Thank you so much. Good evening, Dr. Durie. Thanks so much for this webinar. Appreciate it very much in the recap. Concerning slide number 27, related to the 1114 subtype, right. I just need some clarification. Is it stating or indicating that 1114ers would still require a stem cell transplant if they were successfully treated with venetoclax, or is venetoclax being used to perhaps replace a stem cell transplant?
Right. Very, very good question, and I should have explained that a little better. The venetoclax right now is being used in the relapse setting. And so we don't quite know its added benefit earlier in the disease. The role of the transplant is a separate analysis, where a separate analysis looking at patients in the frontline setting shows that patients who are being treated should certainly have a stem cell transplant. And now, how much better will the treatment be if they have, for example, most of those patients in that graph had VRD plus or minus a transplant. So how much better would they be if they had VRD, transplant, and venetoclax? That's what we're going to have to find out moving forward, okay? And so this is a way in which precision medicine might end up working, where with the 1114 patients, we might say, well, definitely we should try to make sure they can have a transplant if possible, and then try to slot in the venetoclax to get an added benefit. But these are steps for the future, okay?
Okay. Do all 1114 cells express the BCL2, and how would you actually test for those levels?
You have got such excellent questions.
Thank you.
So there's not 100% correlation between the 1114 and BCL2. And so some patients have high levels, but actually some don't. And then some high BCL2 don't have the 1114. So there's not 100%.
Oh, I see. Okay. So okay, now I understand that. Okay.
And so the best
yes.
and the simplest is to use the 1114. That is the strongest indicator. But we can measure the BCL2, and so that is another way to try to see if
okay, so as an 1114 patient, I really don't have to worry about getting the BCL2 levels measured at all. I just know I have 1114, and that's good enough.
Exactly. But great question.
Okay.
Yeah.
Very good, sir. Thank you.
No worries.
Your next question comes from the line of Michelle. Your line is now open.
Hi, Dr. Durie. Thank you for the excellent review. I wanted to ask about the CAR T cells. Are the CAR T products from the different companies pretty equivalent in terms of safety and response?
Right. So again, an excellent question. So the products which are currently available, I touched on the ones that were presented at ASH. So that there is the Janssen product, and as I showed you, that seems to be really quite safe. And then also this new H-Rain product also seems to be rather safe. The other major product available is the Celgene BB2121 product, where it also is very safe, although when they started out, they were the first ones where they were experiencing a little bit more of the cytokine release syndrome, and so they modified the dose, etc., to try to compensate for that. But basically, the two main products, the Janssen product and the BB2121, are fairly equivalent in terms of the toxicity and also the benefit. The BB2121 was presented the year before at ASH and has actually even been published, and so maybe a little bit farther ahead, but also high-level benefit and good remissions. In the relapse refractory setting, the remissions seems to be lasting about a year. It was 11.8 months, for example, with the BB2121.
Okay. And do you know anything about the CAR T cells that are just being introduced in this country?
Yeah, there's different ones. I mean, I think that people joke about this. This is these CAR Ts. What we have is the Model T as well. I mean, I think there's going to be the Ferrari version coming along. I think that these are the initial CAR Ts, which will probably be approved first, but rather quickly, I think we're going to be seeing some modified and upgraded CAR T cells, both in terms of safety and efficacy, and so this is the starting point of a whole exciting approach to treatment, but it's far from the last step,
But do you think it's reasonable to do a clinical trial with a phase 1 study of from one of the newer CAR T products?
I think that's on an individual basis. Maybe you could call and we could talk about that offline. I mean, there's some pros and cons with some of these depending on your situation. And the sequencing, I mean, if you take one BCMA product, then it might exclude you from another one. There's a number of tricky points to consider. So this is something to talk through very, very carefully with your doctor. That's for sure. Okay.
Okay. Thank you.
Your next question comes from the line of Charles Shanley. Your line is now open.
Hello, Dr. Durie.
Hello.
Does the superb performance of mass spec mean that we should depreciate next generation sequencing and next generation flow? And what about the cost of? Because I understand these machines are very expensive.
Right. So again, excellent question. And so we're, as I was saying, we're still trying to understand the meaning of a positive with the mass spec. But it definitely does seem to be quite sensitive. The cost of mass spec is rather good. I mean, it costs about $120. The raw cost is $125, so much cheaper than NGS or NGF. I think for the time being, we're looking at them as kind of complementary technologies. You know, where, for example, a mass spec probably allows us to identify patients who maybe have residual disease, but maybe it's indolent disease, possibly. But we have quite a bit to learn. But the advantage is that the mass spec is going to be a cheap technology, and it's a blood test, and so. Another thing we're looking at is NGF in the blood, so picking up myeloma cells in the blood. So I think that these testings are in the stage of evolution right now in terms of their sensitivity and how we're actually going to use them in a practical way in terms of what decisions will we make if one of these tests are positive or negative. And so it's very important to realize that these are trials and they're not really sufficient to make an individual patient recommendation, actually. Okay?
Thank you.
Okay.
Your next question comes from the line of Angela. Your line is now open.
Thank you. Thank you, Dr. Durie. Wonderful presentation. We appreciate it so much. I wanted to ask you about if there's any data out there about re-challenging with daratumumab for a relapsed myeloma, someone who's had it before and perhaps a different combination of medications with DARA.
Right. Well, certainly as part of a combination, there are data to say that is definitely worth considering. But there's a lot of interest right now in re-challenging. For example, if you've gone off daratumumab for, let's say, 6 months and then re-challenging, we do know that the CD38 can recover, and there's also interest in ways to increase the expression of the CD38, and so it's definitely something worth considering and talking to your doctor about. But especially if you've had like daratumumab with dexamethasone or with one combination, you could certainly consider it as part of another combination, or going back to a weekly dose versus a monthly dose, for example. Yeah.
Wonderful. Thank you.
Again, Marlogie.
Your next question comes from the line of Marlene. Your line is now open.
Thank you. I have a question. My husband's been on DARA for about 6 weeks. It's been started in relation to relapse, and we see no sign of improvement in the M spike. I'm wondering also about the how when the platelets are low and hemoglobin is low, how safe is it to add more drugs? Pomalyst, he's been on that for a couple of years, and
Right.
Dex. His doctor is holding the line on it to saying it's cumulative, but we
Right.
see no results.
Right. So these are obviously tricky points. I think that you certainly don't want to give up too soon, but you're getting to the point where 6 to 8 weeks, if you're not showing some benefit, the maximum benefit is frequently in those first couple of months. So, and then you're raising a very good point if the blood counts are low or it may be difficult to use a combination, and so. Again, got to talk carefully to your doctor or get a follow-up consultation, but it may be that DARA alone or part of a combo is not going to be the best. Unfortunately, it doesn't work for every patient. It works. It's a great agent, and the percentages are good, but they're not 100%, unfortunately. So it might be that you need to talk further about what would be another option. Maybe one of these BCMA approaches that I was mentioning. There are a lot of trials available. It might be, and it's better to be thinking about that and looking at that at this point when you're not seeing benefit. Okay.
Thank you.
No worries. So I think we maybe have at most time for maybe one question more, a short question, and we're going to have to close because we like to keep it as close to the hour as we can. So maybe one more question.
Your last question comes from the line of Fred. Your line is now open.
Hello, Dr. Durie. Thank you for the presentation. I happen to be a member of the 1% of non-secretors.
Okay.
Which I throw off no proteins, and it makes my disease very difficult to follow. I was diagnosed in 2010, so I'm into the refractory era now. My question is, have there been any, is anybody working on other types of tests beyond PET scans and bone marrow biopsies to follow the disease of folks who don't have a protein spike?
Okay, well, the brief answer is that you would be an ideal candidate to check your blood using this mass spec technique. And in fact, there is the possibility to have your doctor send a sample to the Mayo Clinic, and they will run the mass spec on your blood to see if maybe you do have a protein that shows up using this mass spec approach. So that would be the first thing I would suggest.
Okay. Yes,
so if you're having difficulty with that, please call the hotline and we will help you to connect with the correct person. And it's a simple blood sample, but we can try to help you with that as needed, okay?
Okay, I appreciate that.
No worries. So I think we'll have to close now. So thank you for all your interest, and I'll turn it over to Susie, who I think will have some closing comments for us all.
Thank you, Brian. So, and I'd like to also chime in with, I think, was very outstanding and very informative. I'm sure everyone on the call tonight appreciated the information, and most likely a lot of tonight's listeners will have some follow-up questions. So I suggest you call our info line, and they'll be able to help you. That's a toll-free number, and it's 800-452-2873. So I'd also encourage you to please check out our website at www.myeloma.org, and you'll find a wealth of information, including a replay of tonight's teleconference, as well as Ask Dr. Durie and the Best of ASH, which are the highlights from the American Society of Hematology. You'll also find the Hope blog and the Cure blog, which are also both very informative. And finally, I'm sure that many of you have questions, so please don't hesitate to call our toll-free info line, 800-542-2873. And Missy, Judy, and Paul have a wealth of information, and they are there to answer your questions. I'd like to thank Bristol Myers Squibb, Janssen Oncology, Sanofi Genzyme, and Takeda Oncology. And I also just want to give a shout-out to our support group team who just crisscrosses the country, and they do a fantastic job. So that's it. Have a wonderful evening, and I hope to see you all soon.
Thank you so much, Susie. And so good night to everyone from myself.